From the standpoint of the interventional endoscopist, if we look from the upper portion of the gut all the way to the lower portion of the gut, let's look at the areas that we could participate in patient care. When individuals have complications related to acid reflux, for instance, Barrett's esophagus with nodules, we have the ability to take out those nodules with an endoscope and then treat the residual areas of the Barrett's esophagus. We perform procedures with endoscopic ultrasound to diagnose submucosal bumps. A lot of these are benign, but it provides patients as well as referring physicians a lot of reassurance to know that you've actually taken biopsies of these areas. We can look at various portions of the pancreas. We can look at the body of the pancreas. We can look at the tail of the pancreas. And if there's been an abnormality detected on a CT scan or an MRI in the pancreas or surrounding lymph nodes or other structures, we have the ability to take biopsies from these areas. ERCP has been one of my main focuses for the last decade. We have the ability to treat stones in the bile duct. We can treat and palliate cancers in the bile duct. We occasionally will also address issues related to the gallbladder by way of this scope. When the pancreas duct is blocked, for instance, by tumor or by chronic pancreatitis, we have the ability to use endoscopic ultrasound as well as ERCP to provide maximal beneficial impact for the patient via minimally invasive approach. Occasionally we'll have tumors blocking the small bowel, and again we have the ability with therapeutic endoscopy skills to place a stent across those areas to allow those areas to be opened up such that food that the patients eat can now undergo the normal digestive process. Occasionally in patients who have colon cancers, there is an obstruction. And when an obstruction occurs in such a setting, prior to the advent of colonic stents, these patients would undergo a surgical procedure to resect that portion of the colon. Because the colon is not clean, because the patients have not been able to take a prep, a lot of times these patients would end up with a colostomy which would stay in place for about 3 or 4 months. Nowadays, with the advent of colonic stents, a stent placed as a primary intervention in these patients allows staging and bowel prep to be completed satisfactorily and allows for a single one-stage procedure where the tumor is subsequently resected and a primary anastomosis is created, avoiding the need for a colostomy for a period of several